This surgery shows a patient with implant placement in a standard single-tooth gap in the right mandible. In other words, in a site with sufficient bone volume, requiring no bone augmentation procedures. The 26-year-old patient was referred to the clinic with 3 congenitally missing premolars, 1 in the maxilla and 2 in the mandible. Today, a Straumann standard implant will be inserted in the right mandible. The remaining baby tooth was removed about 2 months ago. The implant surgery is performed in a block anesthesia of the mandibular nerve. The mirror view demonstrates a single tooth gap with fully intact neighboring teeth. The gap has a sufficient mesiodistal dimension for an implant-supported crown. The surgery is initiated with a mid-crestal incision utilizing a 12B blade. The incision is extended through the sulcus to elevate 2 small mucoperiosteal flaps without relieving incisions. Small flaps are mobilized with a fine tissue elevator made by Hugh Freedy. One end is pointed and is used to carefully loosen the papillae. Whereas the paddle-shaped end is used to get underneath the mucoperiosteal flap to elevate the mucosa. The goal is careful low-trauma tissue elevation to minimize the tissue damage to the flaps. The flaps will be held in position with 2 retraction sutures. The fine 5/0 suture is applied from the inside of the flap, going back through the mucosa like a mattress suture. Then the suture is attached to a hemostat. The moderate weight of the instrument is sufficient to keep the flap away from the bone surface. The same procedure is carried out lingually. With this technique, no surgical retractors need be used inside the flap during the entire surgery, minimizing trauma to the soft tissues. The mirror view demonstrates sufficient orofacial crest width for the insertion of a standard screw. The extraction socket of the baby tooth is fully healed. The next step is to carefully smooth the crest with a 4mm round burr in counterclockwise rotation. This step carefully flattens the crest surface without taking off too much bone. In general, bone preparation is done with ample cooling, using a chilled saline solution from the refrigerator. The preparation of the implant bed is started with a number 1 round burr. The position of the implant is chosen approximately in the middle of the gap. The position of the first preparation is checked with a periodontal probe. Ideally, the implant shoulder should be close to the reference line applied buccally. Here, the first preparation should be moved slightly more to the buccal aspect. This is how the preparation is moved buccally, utilizing the first round burr again. As a next step, the initial preparation is enlarged with the second round burr. Before the first pilot drill is used, the lingual bone anatomy is explored with a Lukács instrument. In this case, no lingual undercut is present, allowing easy preparation of the implant bed without the risk of lingual perforation. The site preparation continues with the first pilot drill. To avoid overheating the bone, A reduced speed of lower than 800 RPM is used, with ample cooling and light hand pressure. It's especially important that the direction of the drill be correct. The preparation depth can be controlled using the markings on the drill as reference lines. The first line is at 6 millimeters. Preparation continues until the 12 millimeter line is located slightly below the bone crest. The implant position is checked again, utilizing the depth gauge with a built-in 5 millimeter ring. The ring indicates the appropriate position of the future implant shoulder in orofacial and mesiodistal directions. The sink depth is examined with the appropriate depth gauge. For reduced bone height, an intraoperative periapical radiograph can be obtained at this stage to check the proximity of the depth gauge to the mandibular canal. The marking is widened with the third round burr. The implant bed is further prepared using pilot drill number 2 with a diameter of 2.8 millimeters. This step is very easy since the drill is guided by the existing bone bed. The entrance of the implant bed is opened up again with the profile drill of 2.8 millimeter diameter. This procedure prevents the next drill from catching on the edge of the cortical crest. The implant bed preparation is completed with the spiral drill of 3.5 millimeters diameter. The bone preparation passes the 6, 8, 10, and 12 millimeter lines to the final sink depth of approximately 13 millimeters. Today, these drills are provided with laser rings. The depth gauge with 3.5 millimeter diameter confirms the correct sink depth and the implant axis. The occlusal view in the mirror demonstrates a buccal and lingual bone wall of at least 1 millimeter, which is important for a good long-term prognosis of an implant. Class 2 bone density requires pre-tapping with a tap mounted to a surgical adapter, utilizing a speed of 15 RPM. Cooling is not necessary at this stage. Pre-tapping is done to approximately 1/3 of the sink depth in such a Class 2 bone. When the correct level is reached, the drilling machine is switched to counterclockwise rotation to remove the tab. Following rinsing, the site is ready for implant placement. A 12 millimeter standard screw implant of 4.1 millimeter diameter with an SLA surface is selected. The implant with a pre-mounted insertion device is removed from the sterile ampoule and slowly inserted with a surgical adapter at 15 RPM. No cooling is required here either. This technique is very user-friendly and easy. The alternative manual ratchet technique is less frequently used at our clinic, and then mainly for wide-body implants in rather dense bone. When the implant gets close to the bottom of the prepared bone cavity, the resistance clearly increases, providing excellent primary stability for the implant. The interface between the machined and the SLA surface is positioned slightly below the bone crest level in such a posterior implant site. The diagram illustrates how implants are placed in posterior sites. The micro-rough SLA surface is located just under the bone crest. The holding key is applied, and the insertion device can be easily removed by rotating the surgical adapter counterclockwise. The occlusal view confirms that the implant is well positioned. A 3 mm titanium healing cap is inserted to extend the implant clearly above the soft tissue level during healing. A 0.2% chlorhexidine gel is applied to the inner portion of the healing cap. This healing cap allows non-submerged healing without the need for a second surgical procedure. The tension-free wound closure can easily be done with 2 interrupted sutures. A 5/0 monofilament suture is used for close adaptation of the wound margins to the implant healing cap. After 20 minutes, the implant surgery is already completed. The postoperative radiograph shows normal peri-implant bone structures with an appropriate implant position and axis. The diagram shows the schedule for post-surgical therapy. The sutures are removed after 7 days, followed by a second post-surgical visit at day 14 or day 21. After a bone healing period of 6 weeks, the implant is ready for prosthetic reconstruction. The radiograph at 6 weeks shows normal peri-implant bone structures. The clinical view demonstrates the implant-supported crown in the buccal view. The occlusal view shows the dimensions of the implant-supported crown. The corresponding periapical radiograph again confirms normal bone integration of the implant and excellent fidelity between the crown and the implant shoulder. The panoramic radiograph shows the original situation at the beginning of implant therapy with 3 congenitally missing premolars in the maxilla and mandible. 2 years later, the panoramic radiograph illustrates the final treatment with 3 single-standing implants and implant-supported crowns. The clinical status at the 6-year follow-up reveals the implant-supported single crown with healthy and stable peri-implant soft tissues. The corresponding radiograph confirms a well osseo-integrated 12 mm standard screw implant with excellent bone crest levels.